everybody. My name is Venina, Gestantes, and this is my presentation. This is a new VTE risk score that is highly effective to prevent maternal death in hospitalization during pregnancy and in postpartum. That's a result of a prospective trial. This has already been presented. These are my disclosures. These presenting learning objectives are published in the site. I have received a travel award for this presentation. Thank you very much for the organization. And the background is that hospitalization during pregnancy is also a risk, and childbirth is the main risk for VTE in pregnancy. Preventing fatal pulmonary embolus is the primary goal of anticoagulant prophylaxis for VTE. The aims of this study is a new VTE that is largely based on Royal College and Chest, a risk score to all hospitalized pregnant women to ascertain its effectiveness in preventing maternal death from VTE until 3 months after discharge. The methods were: it was an interventional study of hospitalized pregnant women in a single high-risk reference center. Patient was classified a low or high risk according to this clinic hospital VTE risk score. Interaction analysis of the main risk factors was performed using OR or Poisson regression with robust variation. The study period was from December 2014 to July 2017. These are the risk factors. The risk factors were classified as high risk, moderate risk, or low risk. The high risk factor, OR greater than 6, and the VTE risk of greater than 3%, scored 3. Moderate risk scored 2. The OR was greater than 2 and less than 6. And the low risk factor, an OR greater or equal to 1.7 and less or equal to 1 point. And this is the risk score. It was in a formulary electronically in the hospital. And the right risk factor, the most patients of the risk, were those who had already had a previous VTE during pregnancy or after delivery, linked to the use of a hormone or a non-risk factor, or the presence of a high-risk thrombophilia, for instance, and phospholipid syndrome, systemic disease like nephrotic proteinuria, sickle cell anemia, systemic lupus erythematosus, and acute rheumatologic disease, hospitalized for a clinical activity of this disease. Immobility in bed for longer than 1 week with a BMI greater than 30, and morbidity in previous gestation with positive thrombophilia, and when the recurrent abortion was not included. Or scored 2 moderate risk factors were a VTE associated with a triggering factor, a low-risk thrombophilia, clinical conditions like cancer in the previous 6 months, chemotherapy within 6 months, cyanotic pneumopathic paraplegia, severe infections like prior nephritis, pneumonia, or puerperal infection, greater hemorrhage greater than 1 liter, age greater or equal to 40 years, and a BMI greater than 40. And a low-risk factor, dehydration, multiple pregnancy, smokers, hyperemesis, ages greater or equal to 45, parity greater or equal to 3 deliveries, any surgical procedure in this gestation or puerperium, and gross varicose veins. Who received pharmacological thromboprophylaxis? The persons who scored greater than 3, and the risk percentage was greater than 3. The prophylactic was done with enoxaparin, that's the only drug available in Brazil, and the non-fractionate heparin was preferred for patients with renal failure or when low molecular heparin was not available. The patient was evaluated on admission, and a new evaluation was done after 1 week if she was already in the hospital, and the patient was reassessed if something changed in her clinical condition, and always the patient was reassessed after delivery, where everything can change. TPX with enoxaparin, most of the patients receiving 40 milligrams a day, started 8 to 12 hours postpartum, no start time on the prescription, and attention to the risk factor for bleeding. If a score was greater than 3, the patient was discharged with enoxaparin for 13 days, and the patient received the drug in the moment of discharge. If she scored greater than 3 and had a high risk factor, the patient was anticoagulated for 40 days. The enoxaparin adjustment of dose for the weight, we follow the Royal College chart, and here is very normal for everybody. And the risk of bleeding was assessed this way, preferring using mechanical methods. The main risk factor was active bleeding, ulcer, uncontrolled systemic arterial hypertension, thrombocytopenia less than 7,000, allergenous thrombocytopenia that's very rare in pregnancy, renal insufficiency, creatinine greater than 1.5, and so on. The study was approved by the local committee and was also registered in clinical trials. And these are the results. These are the flow chart where every patient was assessed in the moment of admission. Then we have initially 11,873 waiting, corresponding to 80,192 patients. And when you see this population, that's a high-risk population, we are reference center, we have patients, 1,000 patients that were already on anticoagulation for another reasons. They were excluded. Then we have 10,194 waiting. This population, we had this high risk, 15% of them were that high risk for VTE, and all they were analyzed. And the 10,000, almost 10,000, 9,000 patients have a score rated lower than 3 and were also analyzed. So which were these risk factors in these patients? Here we have this chart showing you this table in order of occurrence. Majority of the risk factors were due to age. Patients with the age greater than 35 to 49, corresponding to almost 20% of our population. Parity greater than 3, 11% of the patients. We can see it, we don't have a pointer here, sorry, in the total column. Have multiple pregnancy corresponding to 6.5% of the population. This is a huge number. We expect 1% in the general population. Surgical procedure, presenting 4.2% of this population. In severe infection, 3.3. I also would like to call your attention that we are reference center to cancer too during pregnancy. So we have 1.5% of cancer patients in this population. We turn them into very high risk, as you will see. Here we have a chart with a bar chart, and in blue you have the patient who is scored high, a high risk population, and the orange, the low risk population. As you can see here, age greater than 45, parity, age greater than 40, multiple pregnancy, BMI greater than 40% corresponded to 7% of our population. Now our population, 50% of them had a BMI greater than 30. Smoking, cancer, chemotherapy in pregnancy, sickle cell disease, and patients with lupus. What was the adopted therapy? In fact, in this high-risk population, 63% received enoxaparin, 7% of them received lamfractionaparin, and almost 30% of them received only ambulation for risk factor or avarism. Here you see that most of the patients received the enoxaparin 40 milligrams or enoxaparin 16 milligrams. And the risk for bleeding were present in almost 20% of this population, although half of these patients received the chemoprophylaxis. What was this risk of bleeding? Premature breach of movement, use of another drugs, for instance, aspirin, prednisone, that increases the risk of enoxaparin. Renal insufficiency, 3.8% of our population. This is a high huge number. Active bleeding, hypertension, coagulopathy, metastasis, coughing, stomach ulcers, and so on. When we analyze the patients who were hospitalized antepartum and postpartum, We have that the patients hospitalized antepartum corresponded to 34% of population, and almost 7% of them was admitted for delivery. And when we analyze the population that for clinical treatment, we see that this is the high-risk population, as we have seen in the presentations before. It's the same in the population, in obstetric population. 21% of them had a high risk of thrombosis in the moment of hospitalization. When you look at the total patient postpartum, only 11% of them have a high risk of VTE. So this was very statistically significant. When we study the risk factor and the interaction analysis with these risk factors, we have some interesting numbers. What's it? When you study the age greater than 35 and less than 39, but the interaction with a BMI greater than 40, you can see these huge numbers. The OR is greater than 20, and it can reach 29. When you do the same with the surgical procedure, the association with stillbirth, or the interaction with the severe infection, you can see that these numbers are not additive and they are multiplicative. And you can see here with severe infection and great age, OR of greater than 308. And this can be corrected by the prevalence ratio, but they are already huge numbers. If a patient has an age greater than 40, these numbers are also very impressive. As you can see, if he has an age greater than 40, he has a great multiplicity. You see that UR is very big, 29. Interaction with the surgical procedure, with severe infection, with multiple pregnancy, then you can see the association of the risk and the greatest OR of these patients. And when we study multiple pregnancy, that's a common cause of hemorrhage after delivery, and she has a really hemorrhage, then you can see the OR is greater, 35. The association of cancer with chemotherapy is also impressive. The protocol failure, we have the cases of thrombosis. These are good numbers when I see the numbers published before. The patients are different. There are majority of them were half person. We have thrombosis in the high-risk group, receiving the enoxaparin 0.4%, and the low-risk group 0.03% are in the low-risk group. The adverse effects of anticoagulation, we have only 4 patients corresponding to 2.4%. And the discussion is, the strength of our study was a high number of patients who were scored for VTE risk in this prospective study. Hospitalizations for clinical treatment were frequent and corresponded to almost half of the high-risk case. The score application indicated use of TPX in 15% of all the evaluations and was effective in preventing maternal death. From VTE, we have no maternal death from in-hospital or after 3 months, no death of VTE. The high-risk VTE group had an approximately 20% risk of hemorrhage in our study. The 3% risk of VTE in the high-risk group was reduced to 0.4% by the intervention, the anticoagulation, resulting in 87% reduction in risk. The number needed to treat was 3.3, which is a very good number. One limitation of this study is that the incidence of VTE may have been higher for the last 3 months. Conclusions. The VTE risk score was effective in preventing maternal death from VTE with a low indication for TPX. Maternal age, multiplicity, obesity, severe infections, multiple pregnancies, and cancer were the main risk factors for VTE. I have enjoyed to say that this study has been published last month here. Thank you very much for your attention.